Welcome everyone to today's lecture on technique and surgical complications of kidney transplantation. The lecture will be held by Janina Quito. She's a fourth-year resident at our department. Please enjoy.
So I want to welcome you to my presentation today on the topic of kidney transplantation, techniques and surgical complications. First, I want to give you a quick overview. I want to start with giving you some historical facts, then answer those questions on why, who and when to transplant, and get to the point of the standard technique, which we do here at our center at the USZ, because this is very necessary to understand what kind of complications can occur afterwards and how complications can be avoided. And then I just want to have a quick talk about the role of robotic-assisted kidney transplantation. So let's start right away. When we talk about the last 115 years, the first 50 years of kidney transplantation were dominated by trial and error. In 1905, Carroll evolved the first vascular anastomosis, which was a milestone not only in transplantation history. And afterwards, lots of attempts have been made for kidney transplantation. First, kidneys from animals like pigs or sheep have been transplanted to patient arms or thighs. And I really have to disappoint you, but those didn't work. Afterwards, in 1950, there was the first autotopic kidney transplantation, and this graft worked, unless for 53 days, but it was rejected due to immune reaction. In 1951, René Kuss established the first heterotopic implantation of the kidney to the iliac fossa, which has become today's standardized technique. In 1954, the first ever successful organ transplantation was made, and it was between two monozygotic twin brothers. And this kidney worked for 8 years, due to the fact that in a monozygotic genome there is no immunosuppressant necessary. After that, a lot of research has been made on HLA system, DSA, and immunosuppressive drugs, making kidney transplantation the most often performed transplantation of solid organs today. So, kidney transplantation, we can call it a story of success. In this systematic review, you can see that a transplanted patient compared with patients on dialysis have a lower mortality and a lower cardiovascular risk. As well, you can see that there's an excellent long-term graft survival in at least living donors for more than 25 years and over 40%. So when it comes to the point transplantation or dialysis, you can see another study with a huge patient number here from Wolfe et al. That showed that after 106 days, the relative risk of death equals between dialysis and transplantation patients. And afterwards, the risk to die the relative risk of death is significantly lower in transplanted patients. So, let's sum it up again. Why should we transplant? First of all, it reduces the mortality risk compared to dialysis. And transplantation is more economically. It improves the quality of life of the transplanted patient, and it lowers the cardiovascular risk. So, making transplantation the treatment of choice for end-stage renal disease. So, who are we going to transplant on? Well, there are clear indications according to the Swiss transplant, which are if the GFR is lower than 15 milliliters per minute, or the GFR is expected to be lower than 15 milliliters per minute within the next 18 months, or the GFR is less than 30 milliliters per minute if there's a combined transplantation. So when to transplant? Well, actually studies have shown that graft survival is best when the recipient was not on dialysis before transplantation, and transplantation was performed in the youngest age as possible. For that results in better graft function. So how are we going to transplant? Well, as I said before, in 1951, there was the technique achieved of heterotopic extraperitoneal transplantation, and this became the standardized procedure since 50 years. You can transplant on both sides, either left or right, but most surgeons prefer the right side. You can also transplant a left kidney to the right side and vice versa. You will always do the heterotopic extraperitoneal transplantation unless there is a simultaneous transplantation of pancreas or if the patient is very small in size like a child. So to understand the complication deriving from transplantation, we have to know the pitfalls of the whole transplantation process. They can happen either before, during the procurement, on the back table, or during the implantation. So for the procurement, there are some don'ts and do's. Please don't denudate the ureter, as this causes ischemia of the ureter, which can cause a urethral leak afterwards. Don't pull on the artery during procurement, because this can cause damage on the intima and an artery dissection afterwards. Please don't cut any vessels, even if they're not so very small, because the superior and inferior vessels have an important role. I'll explain that afterwards. And if you take the right vein, please take it enclosed with the vena cava inferior, as the right kidney vein is shorter than the left one. It maybe need to be elongated. And keep the extraction time as short as possible, because incidents have shown that there may be a delayed graft function which is higher and a longer extraction time. When it comes to the back table, you can see the kidney with the artery here. As I said before, please avoid trauma. Here you can see the vein which maybe need to be elongated. And here you can see the ureter. Please be very careful when it comes to preparation of the ureter. So, does any one of you know why we choose the external iliac artery over the internal iliac artery when it comes to anastomosis?
Normally, there is less atherosclerosis compared to the external or common iliac artery.
That's perfectly right. We have to be very careful when we choose our anastomotic site. And this should be free of atherosclerotic plaques. And we have to be very careful when we do the preparation, because there are lots of lymphatic vessels, and we have to be very careful with them and ligate them right away to avoid postoperative lymphocyl. And maybe we need to medialize the iliac artery if we put the left or transplant the left kidney on the right side, or vice versa, or if there's a very short renal vein. When it comes to the anastomosis, we will start with the venous anastomosis, which we suture end to side with running sutures, at least at our center at the USZ. Afterwards, we will do the arterial anastomosis, which will also be sutured end to side with single stitches. Here you can see an already reperfused kidney. So when it comes to opening the clamps, we have to check for leakage first. If there's no leakage, we can remove the clamps, the kidney gets reperfused, and then it comes to the urethral anastomosis, which we do according to the technique of Lich-Grégoire as an extravesical ureterocystostomy. This includes a routine placement of a ureteric stent, which stays for 3 to 6 weeks, as well as a decompression of the bladder with a transurethral catheter for 4 days. Evidence has shown that this is the easier, the faster technique, which is accorded less with leakage than the intravesical technique, according to Leadbetter-Politano. So here you can see the operation site with the 3 anastomoses already done. Now that we've spoken about the technique, we can come to the most common surgical complications after kidney transplantation, which are subdivided into vascular and ureteral ones. I picked out 2 vascular complications to talk about. The most devastating one, which is the graft thrombosis, and the most common one, which is the transplant renal artery stenosis. When it comes to graft thrombosis, you have to know that this is the #1 cause in early graft loss. This occurs most often due to technical problems, and it's more found on the venous side than on the artery side. It most often happens in children due to the small size of the children. And if we have a suspicion of graft thrombosis, we have to perform a duplex right away. So does any one of you residents know some symptoms of graft thrombosis?
Maybe hematuria or worsening of the hypertension or anuria.
That's true. Thank you very much, Francesca. It's sudden anuria, macrohematuria, uncontrolled hypertension, as well as creatinine elevation as sign of impaired kidney function. Graft thrombosis is most often due to kinking vessels, to a short right vein, so please elongate if possible, and medialize the iliac artery if needed. Graft thrombosis is an indication for emergency surgery, and even if surgery is performed right away, it most often results in graft loss. Here you can see a CT scan with the renal artery thrombosis. The kidney, the transplanted kidney, is without perfusion. The renal artery is without contrast. The external iliac artery is open. And here you can see that the renal artery is missing. And also in this patient, this graft thrombosis or renal artery thrombosis resulted in graft loss. So as the renal vein thrombosis occurs more often than the renal arterial thrombosis in graft thrombosis, it's very important to have a look on this. There's some RCTs that show that there's no difference in occurrence of thrombosis whether we administer prophylactic anticoagulation or not. So how can we avoid renal vein thrombosis? And I said that before. We can transpose the iliac artery if necessary. We can elongate the right renal vein, usually done with the donor inferior vena cava. Or if we know that there is a history of atherosclerosis, we should do a preoperative imaging to make sure that there's no atherosclerosis or anything else on the transplantation site. So, when it comes to graft thrombosis, time is kidney. We have to perform the duplex right away. If there's no venous flow and the graft is enlarged, this is highly suspicious for graft thrombosis, and we have to do a surgical exploration immediately. There we can do a venotomy or surgical thrombectomy if the graft is still viable. If not, the graft is lost, and it's mostly, as I said before, devastating with over almost 100% graft lost. So time to intervention is the key for success. There's no standard use of endovascular treatment in graft thrombosis. There are only a few small series that report successful graft salvage with endovascular treatment. And there's no satisfactory result with using thrombolytic agents. Let's move on to the next vascular complication, which is the transplant renal artery stenosis, also known as TRAS. It's the most common vascular complication with an incidence of up to 25%, and it's usually found on the anastomotic site. But there has been no clear evidence that one suturing technique is better than the other. So TRAS is symptomatic as hypertension, which is unresponsive to medical treatment, combined with allograft dysfunction. There's an early TRAS, which usually happens within the first 3 months, and this is mostly due to technical problems. And there's the late TRAS, which is mostly due to atherosclerosis. When it comes to diagnostics, Doppler ultrasound is the first one we should perform. And there you could see peak velocities up to 200 centimeters per second. But there's no clear cutoff, and this examination is very dependent on the radiologist's experience. So what we do afterwards is a CT angio with an angiography, which is the gold standard. And the EMA angio tends to overestimate the stenosis. So when are we going to treat a stenosis? Well, the answer is pretty clear. If it's hemodynamically relevant, if the stenosis is over 50%, or there's an impaired kidney function. According to Biedermann et al., endovascular treatment is the treatment of choice, as it showed significant improvement in allograft function, as well as a well-controlled mean blood pressure in all patients. Patency was higher in DES and BMS compared to PTA alone due to high rates of restenosis. And drug-eluting stents work better than bare metal stents for distal stenosis. Let's move on to urethral complication. There are also picked two I want to talk about. First is the urinary leak, and the second one is the urethral stenosis. The urinary leak is mostly because of urethral necrosis in the distal urethral segment due to excessive preparation and denudation. If it comes to urinary leakage, the goal of the treatment is maximum decompression of the bladder and dry out the urinoma. You can do that by urethral catheterization. If there's a hydronephrosis present, please do a percutaneous nephrostomy with or without antegrade or retrograde double-J stent placement. And if there is a collection of urinoma, it should be drained percutaneously, as a urinoma can be infected and leakage won't heal in an affected surrounding. Here you can see a urinoma, and on the left side, a contrast extravasate. According to the Journal of Urology, urethral stents decrease the early urinary complications, but they can cause an increase in urinary tract infections. So it's very important to not leave them very long and remove them without the first weeks postoperative. When it comes to urethral stenosis, this is the most common urethral complication. And the major cause of early stenosis is as well ischemia, and if the lower pole artery is cut, as this one is responsible for the perfusion of the urethra. Comes to therapy. It should be endourological, either with repeated balloon dilatation, retrograde stenting with a double-J catheter, or nephrostomy with antegrade stenting with a double-J catheter. And last call should be surgery. When it comes to surgery, this is an example of what we could do. We can take the urethra from the native kidney, which is still inside, and anastomose it to the donor kidney and also to the bladder. The last complication I want to talk about is the lymphocele, which is a vascular associated complication. And there are some risk factors for developing a lymphocele as excessive surgical dissection, a BMI over 30, and it mostly happens during the procurement. So it's very important, and I repeat myself, to carefully ligate the lymphatic vessels. And lymphocele most often occur after 2 to 6 weeks after transplantation. And it just have to be treated if symptomatic. It can be treated either percutaneously, via CT or ultrasound guided placement of external drainage. And you just have to do that whether it's symptomatic, as I said before, or if it compresses the kidney or urethra. And the external drainage has a high recurrence rate, up to 50%. And you can also drain it internal. So you perform a laparoscopic access and fenestrate the lymphocele wall. Then the fluid will be drained by the peritoneum. And this is a less recurrence rate of 8%. There has been a previous study from GK to go with 240 patients approximately that showed that there may be an advantage in obese patients, but it also shown that the anastomotic time, which is the secondary warmer ischemia, is longer, and which is relevant for the outcome. So it showed that there may be a longer surgical and anastomotic time in robotic-assisted kidney transplantation, but comparable rates of complication. And there might be a possible advantage in obese patients. However, when it comes to obese patients, it is very wise to do bariatric surgery prior to transplantation, as this results in better graft function. So, just want to finish my presentation with take-home messages. Always transplant if possible, and as early as possible. Kidney transplantation is a highly standardized procedure, and graft thrombosis is rare but devastating. Late vascular complications are common, but usually good to handle with endovascular treatment. And there's a possible benefit for robotic surgery in obese patients, but there has to be more research on that topic. Thank you very much for your attention.
Yeah, Janina, thank you very much. Excellent presentation. It's not easy in a short time to summarize this procedure from history to where we are today. And this is a general surgery also procedures, since we see this complication and it's good to know what can happen. The history here of kidney transplant goes a long time. In fact, we published in the 20 years ago, at that time, the use of DCD, so the kidney after cardiac arrest, was one of the first study done in this field in kidney. That is extended to many other organs, was published at that time in the New England. And the main message at that time was, well, they all fail initially, so this non-function, and they come back, and long term. I think there is a study going on now that show even after 20 years or 30 years that these kidney are doing as well. That's what we want to know as the standard organ that are retrieved in brain donor. So my first question, one of those two, I mean, then we have now today the living donors. I would like you to make a comment. I mean, clearly there is a long waiting list. There is more need that kidney we have. So maybe can you tell us who can benefit from living donation and how we can enhance the use of a living donor in this setting?
Well, I think the primary goal should be for a patient that needs a new kidney should be to find a living donor, because we clearly know that the best results you can achieve are from living donors, and this, as Janina said before, as early as possible. So basically, would be best to transplant before the recipient is on need for dialysis, and as you said, for DCD kidneys, it is known that DCD kidneys, initially they have higher rates of delayed graft functions. But as we know now, or as newer studies see, that for the long-term graft survival, there is probably no difference. So this is something to extend the donor pool.
And if you had a question, maybe, I mean, also important in this transplant kidney, but other organ, but transplant is that the interdisciplinary team. And I see that Kerstin is here and she's at least part-time of the kidney team. Maybe you want to make a comment on how important to have the work together between the surgeon and the nephrologist or transplant nephrologist in this field?
Well, I think this is a key to success. I mean, we do this now for a couple of years together, and so we learn from each other. I learned a lot about the surgical part, and the surgeons did learn a lot about nephrology. And I think we have really sick patients. Sometimes people forget this. Nephrology patients are the most sick patients that you can have, because they suffer from a lot of vascular diseases. And compared to this, we kind of had really few complications. And I think the reason is that we, from the beginning, when we list them, when we get when all the nephrologists from outside sending us the information and sending us the patients to transplantation, we start to work them up and we start to prepare them. And so this is essential in my eyes.
I'd be happy to say something about living donors, because the living donors obviously have the best results. And it's not to say that a deceased donation is bad, because if you transplant a patient at the same time with a deceased donor, your results would be much as good. But what we have to know is you need a huge effort to get the living donors in, and you need to see the patients very early. And this is what we always try, is to see the patients as early as possible, so we can talk to the family, talk to the spouses, talk to their friends. And this needs a huge effort. It's not that easy to give your kidney, and it's not a walk in the park to donate your kidney. The results are great, but it's not a walk in the park, and it needs a huge effort to talk to these people.
Yeah, I think it's nicely depicted by Oliver. It is, in a way, although we don't frame it as such, a little bit of a dilemma, right? We have the better of the results than the donation after cardiac death or brain death. But of course, we operate on a patient who is healthy, right? And who doesn't have a problem. And this dilemma that we have, we should also frame it as a dilemma. We know that this is a dilemma, right? And that we have this discussion, we have to be very careful, as Olivier said, to not put a pressure on on the family, especially when it's preemptive, right? So you don't have you're still on dialysis, or you're not on dialysis. You want to operate, and this has to be taken into account. Although we all wish to have the best results, of course, for the person being sick. I mean, that's inherent in this situation, right?
Okay, good. Thank you.